and we will, edit it, making sure that we don't have anything that violates HIPAA, and also make sure that the content is precise enough so it's useful when somebody is able to join in later on to listen in. So just wanted to give a shout out to everybody who's joined in. Thank you for joining in to being a live audience. I'm going to make it a little interesting so we can have some polls as we go along the way. You'll see it on your screen. It's just a list of questions to what is being displayed, and you'll have an opportunity to answer those questions, and we can see, just to make it like a little fun session, and so we can all learn from each other as to how things go and how opinions matter. Everything's going to be anonymous. Nobody knows what you answered or what you actually chose. And we're going to try to do this for the other sessions too, to make it as interacting as possible. So with that, I'm going to start off with this lecture series, and just giving a general idea about observation. So OBS is essentially a status. It's not a location, it's not a specific unit, it's not a closed unit, it's just a status that the patient is in. And it's essentially a status where they are reviewed, and whether their need to stay inpatient is determined, or whether they could be discharged is determined. So essentially it's a period of time, wherever in the hospital it may be, where they get a chance to be reviewed, to be treated upon, and if they get better, they go home. If they don't get better, then they get admitted. CMS defines observation very specifically as a well-defined set of specific clinically appropriate services, which include ongoing short-term treatment, assessment, reassessment, before a decision can be made whether a patient will require further treatment or if they're able to be discharged from the hospital. So essentially, it's sort of like an intermediate decision unit where you decide whether the patient goes in or whether the patient goes out. And often it's not the place where you have the opportunity to keep that patient longer until we know what is exactly wrong with them. And we'll talk a little bit about more as to why observation unit is very precise and concise and should be used just for that determination of whether this patient is worse to be admitted or whether that they are better and they can go home. So to start off our poll, our first question is going to be on why do we have an observation unit? And as soon as I publish this poll, you'll be able to see it on your screen, and you can answer as to what is the most appropriate result or the option. So take a good look at the screen. Why do we have an observation unit? Let me see what is the appropriate option that we all chose. So I'm going to keep the poll open until the majority of you answer, and then we can end the poll and see what everybody has answered. Just a fun bit of a question to start the session off. All right, so let's see what everybody said. So everybody said to provide efficient care in a timely manner. Some of us thought to make the ER doc's life easier. There are many things that makes the ER doc life easier. And the observation unit, I wish they would all like it that way, but observation unit is more than that. It's to give that patient a space where we can perform the care in an efficient and timely manner. All right, so let's go ahead and see how the observation unit evolved over time. So initially, OBS units were very small. This was in the 1980s to 1990s when observation was kind of an afterthought. They were essentially created to have ED patients stay longer because they just needed some monitoring. They were not sick enough to be admitted. So they were put in essentially in ED-based observation units where they would be an extension of the ED, a few beds in the corner where they would stay and then go home or get admitted the next day, depending on how they did. And in the 1990s, observation units started growing larger and larger, primarily because of what we now know as chest pain units, essentially designed for chest pain patients to get cardiac testing, like stress testing, in a very efficient, timely manner. And that was the reason for a significant expansion of the observation unit. And in the most recent years, as you can see, the observation status or the observation units have grown significantly in size, and that's what we have seen generally. But if you look at the overall bed capacity, that has declined essentially because a lot of the stuff that we used to do as an inpatient is now being done either in the observation setting or even in the outpatient setting. So the need for inpatients have gone down significantly, and a lot of them have translated into more of an observation care where you can quickly deliver that care that the patient needed, make that decision about whether you want to start a DOAC on a patient or not, or whether you're going to do Coumadin and keep them longer. So it has significantly expanded, especially with more recent interventions with both antibiotics and anticoagulation. And also with cardiac stress testing, the amount of or the accuracy of the test and the efficiency and the quickness of the results that come back. The observation unit has multiple different names. Here we call the Henry Ford OBS unit as just a plain observation unit. There are multiple other names. They can be called as a medical evaluation and observation unit, rapid diagnosis unit, or a short stay unit, or chest pain unit, or a clinical decision unit. Essentially, all of these mean the same. They're all observation units. And observation status has come to define a large number of patients to an extent that now we have very complicated patients in the observation status, especially in an academic center like Henry Ford, where we get real complex transplant patients sometimes, and who may not need to be admitted, who may just need a few hours of observation. So initially, a lot of observation units were very protocol driven. They used to have a clean pathway for like chest pain or stress tests or COPD or CHF. In Henry Ford, we actually have a mix of different types of care. We have a protocol-based care, which is usually our chest pain patients, where they come in, they get a heart score, or they get a high sensitivity troponin, and then they get a stress testing, and then they go home or stay. Or they can be very complex, or they can just come in with augmentation with no other significant findings, severe enough for them to need inpatient admission, and then they will be observed in the observation unit until a decision is made on whether they get better or they go home. So we have more of a discretionary care, essentially providing observation in multiple different units. At the main hospital, Henry Ford OBS unit in I1 constitutes about 60 to 70% of the total OBS volume. And the rest of the observation patients are actually in multiple different units. And in West Bloomfield as well, we have a dedicated clinical decision unit, but then our patients can be in multiple other units too. Wherever they are, the general principles of observation status remain the same. So generally, we like to have a well-defined diagnosis in OBS most of the time. It may not be all the time. And essentially, it's not the place where you have high needs patients where you need like Q1 finger sticks. And your goal for length of stay is about 8 to 24 hours. And we try to have a diagnostic of therapeutic-driven protocol with multidisciplinary collaboration, and we have multiple metrics and give feedback to physicians who work in the observation unit. So why is it so important to get this thing right? Why is observation so right? So Medicare, if you review the history of how Medicare was formed and how it came to define healthcare in the United States, they covered a lot of inpatient admissions to an extent that the cost of providing healthcare was exponentially high, to a point that they were approving inpatient admissions for patients who just stayed less than a day. And then Medicare was like, came back and said, this is not appropriate. I mean, these patients should essentially be treated more efficiently and should be managed with much less resources than what is needed for an inpatient admission. So they brought on this concept, or they embraced the concept of observation care, in a way that we can provide most efficient care, but at lower costs both to the patient and to the hospital. And to understand that a little more, you need to know essentially how your insurance coverage works. If you are just joining into a group and you just signed up for health insurance, you really need to know how it works. And essentially, we have different terminologies: deductible, co-insurance, out-of-pocket limits, and annual coverage limits. We're going to focus more on the deductible and the co-insurance and why this matters for observation patients. Essentially, with the with the more recent use of high deductible plans, patients in observation unit often will end up paying a much larger amount, especially if the care wasn't provided in an efficient manner. And that's why it's really important to provide very precise care so that we conserve the resources and not have tests or medications that the patients may not need. Um, and if a patient has, if it's the start of the year and their deductible is new and they're in the observation unit, they may be taking on a lot of cost. And there are ways that we can prevent that cost. And as an example, I'm going to show you a video that's going to come up next to see how things are different in terms of medications, in terms of procedures in observation care, and how the patient side of things work, how the patients see in terms of cost perspectives in observation unit. So
You're in a hospital room. You're sick. Nurses check on you regularly and give you medicine. Your doctor has ordered treatments. But you have Medicare, so you figure you won't face a hefty bill. Well, surprise! You learn you haven't been admitted to the hospital. Instead, you are receiving observation care. That means doctors have decided you won't be staying more than 2 minutes. Doctors and nurses are monitoring your condition and watching to see if you need to be admitted, but often, patients can't see the difference in care. Medicare considers observation care an outpatient service, even if you stay overnight at the hospital. So you will likely have more hospital costs than if you had been admitted. Costs like the co-insurance Medicare charges for outpatient care, usually 20%, and the bill for the drugs you may need for your chronic conditions. So here's a comparison. That baby aspirin you take for your heart condition, it could cost $18 at the hospital, instead of the pennies you're used to paying when you buy it at the big box store. And because Medicare has no limit on out-of-pocket charges, it can all add up fast.
So this is sort of the key in observation care is patients share part of the cost on what you do. It's different from inpatient care where the entire payment is paid as a single bundle, whereas in observation care, it's almost like an outpatient. And if you had received outpatient care, you know that if your doctor orders a chest x-ray, you have to pay a separate copay for your chest x-ray. If they ordered a medication, you need a separate copay for a medication. And there are multiple ways of how this is structured uh, for outpatient services. And because observation is considered as an outpatient service, essentially everything that you order in the observation unit will have a copay or a co-insurance for the patient. So it makes a lot of sense to give a very precise care and not order medications or tests that the patient may not need or can be done as an outpatient, which will be extremely beneficial both for the patient and for conserving resources from the hospital side. So we have another question and another poll. So this is Mr. Smith, who's an 80-year-old male who presented to the OBS unit with diarrhea and fatigue and some pre-syncope. He was orthostatic positive in the ER, lights are normal with a small lower potassium level. The CBC is normal, vital signs are stable, serial tropes are negative, EKG shows no acute changes. Upon arrival to the OBS unit, his daughter is yelling to you that she wants him admitted because she saw on NBC nightly news that you will have to pay thousands of dollars out of pocket. So what do you do? So take a look at the different options and then you'll get a chance to answer which one is more appropriate. So do you want to admit Mr. Smith for having good HCAP scores, or you want to call the case manager to talk to the daughter, or have the nurse practitioner talk to the daughter because you have so many more patients to see, and explain to the daughter that they don't meet criteria for admission and her stay may be denied, costing more in the long term. All right. So let's see how everybody did. Everybody did pretty good. So you got the right answer. And that's how we're going to go into the next part of this discussion, and see how that looks. Okay, so the reason why this is very important is this next slide. So this is a typical breakdown of an inpatient versus an observation care for pretty much the same diagnosis. So let's consider a patient with pneumonia who was admitted and who had a length of stay of 22 hours and was discharged from the hospital. So let's see what happens if their cost is approved. And they would, be covered for pretty much everything. They will pay a small copay of about $100 for the entire inpatient stay, because inpatient stay is a bundle, and everything is covered under the cost of care. Versus what happens to that patient if they were in the observation unit. So in the observation unit, they're going to pay separately for each and everything that you did, your antibiotics, your bed charge, your pharmacy for your other medications, the imaging that you did, the lab test that you did, and they're going to have a much higher pay, and depending on what their deductible is, it can be much more higher than $500. So the reason why I wanted to bring this up and why Mr. Smith's daughter may benefit from this information is that if Mr. Smith did get admitted and his claim was denied, which Medicare certainly can do because they have auditors who review cases in observation and inpatient and decide whether there was an overuse of inpatient stay and why this patient cannot be in observation. So if this claim got denied for an inpatient stay, unfortunately, Mr. Smith would have been responsible for an enormous amount of cost instead of sharing that cost under the observation status. So it's very important to get this status right. And the reason why we need to get this right is because it has enormous complications for both the hospital and the patient. And in order to do that, we have the next element of observation, which is essentially our IPAS team and our transfer team, or ATMO team that we call it here, the admissions and the transfer management office team members. So one more question, everyone to answer. If you're able to mute, please do so. All right, so one more question for everybody to answer. What does RAC stand for? And let's see how everybody is doing on this one. So what does RAC stand for? Is it Rent-A-Center? Is it Rochester's Aquatic Club? Is it a Resident Action Committee? Or is it a Recovery Audit Contractor? So everybody got it right. So RAC essentially stands for Recovery Audit Contractor. The reason why we need to know that is these audit contractors are appointed by CMS, and they review every inpatient stay and make sure it is appropriate. And if it's not appropriate, they will deny the claim. And then the patient is going to be responsible, or the hospital is going to be responsible for bearing that cost. So in order to make sure this doesn't happen, CMS actually mandates hospitals to screen all admissions. So screening criteria should be utilized by having a team called as utilization management. And this criteria should look at both severity of illness and the intensity of treatment. And cases that fail should be referred for physician review. And the team that does the physician review is called as our physician advisory service, or the physician advisory team. And ATMO, our admission and transfers office, often does that initial screening that is mandated by CMS to do. So they do an initial screening based on multiple different criteria, which are called as interqual and Milliman's criteria, and they see if this patient meets criteria for admission, and if they don't, then that gets downgraded to observation, or sometimes if they don't meet observation criteria, that gets downgraded even further to outpatient. And if there is any questions or concerns regarding this case, it gets reviewed to a second panel made up of physicians. This group of physician advisory team is made up of multiple different specialties. Sometimes our hospitalists are part of the team. At Henry Ford Downtown, we have two former ACMOs who are part of the team, with another nephrologist and an ED physician. So a multidisciplinary team actually reviews this case and ensures what happens to that patient. And often, this is where there can be some questions as to whether this patient is appropriate for observation. And that's what we're going to just review in the next slide, as to what to do when you have cases that seem like they're not appropriate for observation, and you're wondering how they ended up in the obs unit. So to make sure you make that right decision, to make sure you make that right call, you have several levels of support. So first is when you are reviewing a case for accepting to the observation unit, or you're looking at that patient who's presenting before you, always review what is the intake policy based on the site. Different sites, Henry Ford Maine has an intake policy for different patients. Henry Ford West Bloomfield has an intake policy for different patients. Some of the examples are, downtown observation unit, we usually don't have patients on dialysis if they're coming in just for observation, unless they have other medical conditions going on. At Henry Ford West Bloomfield, we do have, we don't have patients on dialysis. They end up going to other floors in the CDU. And then there are differences based upon like surgical services. Some services are placed in observation unit at downtown, some are not. So you need to review what your intake policy is at each site, and that is usually shared with you on orientation when you are going to be ready to work in the observation unit. And if you still have a concern about a case that was very difficult, and we look at a specific example in the next slide, and how to figure out which is the best way you can care for that patient. Speak to the ED staff when you get sign out on a patient who feels like, who you feel, that is not quite appropriate for observation. And oftentimes you're able to solve the question there as to why a patient needs to come to observation. And if you still have a concern, you can always talk to the IPAS physician as to why they did not meet criteria based upon the Medicare's review based on different criteria. And these criteria often change yearly, and it's very difficult for every individual physician to keep track. And that's why our IPAS physicians often monitor that and make sure we do the right thing and protect the patient from inpatient denials. And if you still can't solve the problem, always accept the patient to the observation unit and inform the obs medical director at your particular site if you still feel the patient is not appropriate. So one example that just happened recently that I wanted to come across is that kind of chimes in with this patient is often when you are the accepting physician on the phone trying to take a call, and you receive a patient like this that obviously is very sick, has a lactate of 12.8, has an elevated beta hydroxybutyrate, and the ED physician is calling you for admitting to observation. So something definitely was amiss here. One way to figure out is to actually talk to the physician, to the IPAS physician or the ED physician, because sometimes they don't have all the data available to them when that determination for the level of status is made. And talking to them and giving them an idea about the change in the status of that patient will help you to better decide on which patients are okay to accept to the observation unit. So in this case, the patient was very sick. We did take this patient to the observation unit. Patient left to the ICU in about 5 hours. And apparently we discovered that the IPAS MD did not have all that information with them. When they reviewed the case, the patient's gap was closed. They did not think the patient was septic or was in DKA. So they felt the patient just needed a few more hours of monitoring their glycemic control, but unfortunately, the patient did turn for the worse. So that often helps to helps you in the observation unit when you're working there, if you have concerns about patients being classified under the observation status. All right, so what else can we do to improve and make our care more efficient in the observation unit? So one of the biggest tips that I would give you is make sure they have an observation order. Every physician who's taking care of observation patients should have their team place an observation order. And this is mostly the hospitalist team that is taking care of patients in the downtown hospital and at West Bloomfield and at Macomb, we have different groups. So whichever group is taking care of that patient, that group's team member should be placing an observation unit. The odds order that was placed in the ED will not count. And if you don't do the observation order, then if you can see on your right side, we lose a lot of revenue for such patients. So it's very critical that everybody who has who is in the observation unit has an observation order. And one quick tip will be to do the observation, initiate observation status order, and then do your H&P. When we audit charts, often we find that there is a lot of revenue loss, especially because one, the order is not placed, or two, the order is placed after H&P is done. So one quick tip to work in the observation unit is always make sure you place the observation order and then do your H&P, and that will make sure that the patient is in the right status and is not billed as an outpatient. And a couple of other tips, especially because observation units are places where you work with advanced practice providers or nurse practitioners and PAs. And it often makes sense to document very crisply, especially when you're testing their notes. So I have three different examples here. Example one is in the top, example two is in the middle, and example three is on the lower corner. And I'm just going to ask you by polling, what do you think is the best attestation that is enough for one, capturing billing, and number two, what is enough to define and enough to make sure your care is efficient and you don't spend too much time on each and every patient. So tell me, based on the examples that you see or you saw, what is enough or what is an appropriate attestation in the observation unit? All right, so this is how we answered. Majority of them got it right. The option one is often enough, or almost always enough to bill that patient for observation services and to bill 100% for observation services. Example two, although looks enough, it's actually not. It doesn't give us any idea as to whether the physician saw that patient with the advanced practice provider. Doesn't have enough information in there to substantiate that the physician or the provider was there to see that patient as well. And remember, almost all the services in observation, when we work with advanced practice providers, is billed as a shared service, and all shared services needs that one, the nurse practitioner, the PA should have seen that patient, and number two, the physician also should have seen that patient. Example three is very well written, is really wonderful, but unfortunately is too extensive of a documentation and maybe a little bit on the higher side of documenting. And often the disadvantage of doing this is it takes a lot of your time, and you really don't get any extra credit for writing such a long descriptive note, although it helps to explain especially for patients who are very critically ill, if you're going to do that, rather than put that in the attestation, it's often really helpful to do a separate critical care note, especially if you're having patients who go from the observation unit or get really sick and end up going to the ICU. Instead of writing a very detailed attestation, document a separate critical care note and document the amount of time you spend. That is often more efficient and often helps us to capture as much from the encounter as possible. All right, so another tip when working in the observation unit is on documentation. So another poll that's going to come out to you on documentation. So take a look at example A and example B, and let me know which do you think is the most appropriate documentation. So this patient came in for COPD exacerbation and had other comorbid conditions that was going on in the hospital, and did not quite need to stay for an entire day, was actually doing much better, and was later on discharged in about 22 hours. But this was the documentation that was in the chart, and just reviewing this, we can talk about kind of making your documentation in the unit more succinct, so we can be more crisp in documenting what was going on. All right, so let's see how we did. So sort of like a mixed result here. So example A and example B, a lot of folks thinking that example A is more than adequate. So this patient has a lot going on that may not be really relevant to the COPD exacerbation that they had, but is still relevant in the realm of comorbid conditions that they had. So when you are in the observation unit, try to have at least 3 to 5 diagnoses in your assessment plan. Sometimes, it's very difficult when the patient has really nothing else going on. To document more than 1 or 2, it may be difficult, which is understandable, but majority of our patients have something going on. So it's often really helpful to document the other comorbid conditions and what you're doing for them, and if they are either controlled or uncontrolled. So in this scenario, option B is often the better documentation. And the reason why that is better documentation is especially evident, one, when you really are trying to admit this patient to the inpatient side. Say the patient did not do well and you're trying to admit, and if you have just one diagnosis on your list, it's going to be very difficult to substantiate the need to justify that admission. And often this leads to more denials in the back end and a lower reimbursement overall. So this is an example of a patient who had hypertension and came in with CHF. And you can see how just documenting CHF unspecified versus mentioning all the different comorbid conditions that the patient came in actually increases your major comorbid condition billing and also increases your case mix index. So when I was having a conversation with one of our hospitalists who was new to the group, they were really not aware of what a case mix index was. And, obviously this is not a topic that is taught in residency, but it's very relevant to what we do on a day-to-day basis, either on the observation side or on the inpatient side. We need to know, what are the other comorbid conditions that are going on with the patient. And that is true in the observation status as well, especially when, if you document too little, there's often questioning as to why this patient even needs observation. So if it's a level 1 observation patient with just one diagnosis, there's often questions from the payers as to why this patient needed observation. So often documenting the comorbid conditions is very essential in, one, substantiating your case, and number 2 is when the patient needs to go inpatient, and number 3 is making sure that we accurately reflect the amount of care that we provided, so we get the appropriate reimbursement for that. And some of the tips in documentation rather than saying CHF or hypertension, try to be more specific, try to use diagnosis rather than symptoms. So using, especially on discharge, even if you use it on admission, that is okay. If you're on admitting, you're not sure what the abdominal pain is from, that is fine. If you're not sure what the chest pain is from, that is okay. But when it's time for discharge, always make sure that you have a more specific diagnosis because it's very relevant for one, making sure that we capture that major comorbid conditions. And number two is if you're admitting that patient, often having a more specific diagnosis makes it much easier for that patient to qualify for inpatient admission as well. So that's something to remember. And just some final thoughts, observation unit at multiple sites. We have the help of our wonderful advanced practice providers. But I just wanted to lay out some expectation for APPs and physicians in the different units. APPs, make sure you assess and document notes on time. Follow your site-specific workflows for patient assignment and for seeing and ordering and consulting, and discuss your care with the ops doc when you have the chance. And sometimes APPs can independently manage patients, and if you're doing so because it's a busy day or there's only one physician available and you have a lot of patients on your list, or the physician has been pulled away to a different task, use your triage criteria that should be there at our different sites as to what do you need to really discuss with your physician versus what you can manage by yourself. And for our physicians, when you work with advanced practice providers, be there to give oversight to the care and be available for rounding with our APPs, and especially when help is requested on early discharges or on nighttime calls. And it's very essential that all our patients are seen physically because observation is a split shared service. So if we have an attestation saying or not being able to substantiate that you physically saw that patient, then we won't be able to bill for that patient. And make sure you attest all your nurse practitioner PA notes on time. It is expected that you will attest patients on the same day. If not, make sure you are able to attest it and document that you did see that patient on the time of the encounter. And one more question, a final one to determine management in the observation unit. So you have a 71-year-old female with chest pain who was placed in the OBS unit at 7 p.m. on December 31, and you have determined that she requires a nuclear stress test because she has an underlying left middle branch block and an EF of 30%. The stress lab tells you that because of the holiday on January 1, they won't be able to do it, and you got to keep the patient till January 2 because they will have to pay the techs overtime, and they don't want to do that. So what are you going to do? And let's see how we're going to answer this one on the poll. So you should be able to see the poll real quick and choose your appropriate answer. So are you going to admit the patient using the 2 midnight rule, discharge the patient, let our cardiologist deal with it, tell her that Medicare will not cover her stay and hope she leaves AMA, and keep the patient in the observation unit given lack of medical necessity? All right, so sort of mixed results there. Some of us thought that we should admit this patient using the 2 midnight rule. And let's try to decipher as to what we need to do here. So, and that kind of flows into our next slide. So we'll talk about this while we're discussing the other question. So when can you admit, deciding to admit a patient in the observation unit? So obviously when there is ongoing medical need for a patient, when they have to stay here for more than 24 hours, yes, by all means, they need to be admitted. Our goal of patients to stay in the observation unit is less than 24 hours. And if there's a sudden change in the conditions, if the patient's like hypertensive or the lactate's going up, or they have frequent nursing needs, like they need very frequent finger sticks, or they need very frequent neuro checks, and they're really not getting better after the initial observation period. And if they have worsening, risk scores, like the MEL score went from 15 to, 32 the next day, that's a case to keep the patient. And if there's any change in the code status to like comfort care or hospice, then we may need to admit that patient. So when you cannot admit a patient is when there is a testing delay. So when you are not able to keep that patient because your stress test was not done due to bureaucratic reasons, or if there's a consultant delay or consult physician did not see that patient on that same day, if there's an insurance authorization delay, if there's a family delay because they're not available and they left out of town, and there's nobody there to take care of that patient, and there's a discharge location delay, let's say the rehab doesn't have a bed, or there's lack of documentation. So whenever you want to admit a patient, you need to substantiate why, and that needs to go through the Medicare review process with ATMO and IPAS to make sure that that patient qualifies for inpatient admission. So whenever you admit a patient, always have a note in the chart before you call in for admission, and follow the site-specific protocols on what you need to do. So going back to the previous question, that does not meet the medical necessity. A hospital protocol to not do a stress test on a holiday is not Medicare's problem. So that patient we cannot admit to inpatient because there is no medical necessity, it will be denied. And that patient unfortunately will have to stay in the observation unit. And that's why it makes sense when you have a patient in the obs unit who might need a consult, make sure you call the consult early in the day, or at West Bloomfield, that happens automatically, but at the main hospital, or if you need to reach out to the consultant and let them know that this is an observation patient, or if they're pending a test, for example, a CT, and that's being scheduled late, call the radiologist and tell them that we need this to be expedited because the patient is in observation, and testing delay is not a reason to keep the patient longer. Um, and just going into the next set of slides. So just wanted to finish off by looking at some of the metrics that we do in the observation unit. We follow a lot of numbers, and some of the important numbers that we follow that you need to know is, one is the length of stay. Make sure if your patient has medical necessity and needs to stay for more than 24 hours, that they have a chance to be admitted. And also try to, if your patient is here for some reason for longer than 24 hours, and if they have Medicare as their insurance, then you need to be also extra careful as to keeping them another day. So those patients, we identify early on, and if there's ongoing medical necessity, we need to admit them as well. Our goal for the patients to leave the hospital after the discharge order is placed is close to 60 minutes to 90 minutes. Nobody should wait for like 4 hours for to leave the hospital after a discharge order is placed. So that's something to keep in mind. And also try to round early, try to get those early discharges in, especially that patient who has nausea, vomiting, who's able to eat now the next day and he looks really well. Try to get that discharge early prior to rounding in the morning, prior to doing your progressive rounds. And that's also something that we follow, is discharges prior to 10 o'clock. So overall, just points to remember from the lecture, observation is a status, it's not a location. And it applies to any patient anywhere. And whenever it applies, you have to make sure that that is an outpatient service, and everything that you order, including multivitamins, fish oil, and over-the-counter supplements, everything is going to carry a cost to that patient. So be careful in ordering tests that are not needed, especially like an outpatient follow-up test. Remember that observation is not an expedited PCP service. Just because they couldn't see their PCP for 3 months, doing a lot of the outpatient workup is not appropriate in the observation unit. And try to expedite tests and consults by calling in early, reminding them that this patient is in observation. Use the observation order class when you order a test. Whenever you order a test, there's actually a way to label that test as an observation patient. If you look at it, it'll have routine, it'll have stat, and it'll have observation. So choose observation when you're ordering tests. The only test that we don't do on a stat basis is an echocardiogram. If you need an echocardiogram on a stat basis, call your cardiologist. That patient should likely not be in the observation unit. And be very patient-centered. I mean, we're all working towards our patients and essentially trying to give the most efficient care so they have a lower cost of care with higher quality in a very efficient time period. And that is the goal of observation, is to provide efficient, timely, safe care with utilizing as low resources as possible. And with that, we'll take any questions about what was discussed so far. This is just a rough overview observation. If you have any questions, please unmute yourself and fire away, and we'll see if we can have we can answer them for you.
Hey, Bright, this is Matt. Very good presentation. I just want to add a couple things in. We did talk a lot about kind of the 2 midnight rule and Medicare and meeting criteria and what's appropriate and not. One thing, not all of our patients are Medicare, so a lot of our patients have private insurance, and unfortunately, private insurances get to set a lot of their own criteria. HAP is notorious for this, to set their own criteria of what meets observation versus inpatient care. So sometimes you just kind of have to play the game that the insurance company does. If HAP insurance requires 48 hours of IV antibiotics for cellulitis, then sometimes you have to keep the patient observation for 48 hours of antibiotics before you can admit them. So it is something frustrating, and these private insurance companies can do, the commercial ones, but that's just one thing I wanted to add. Another thing you talked about, kind of patient expense, Medicare patient expense. You did a great overview. It's just, if patients or patients' families ever ask you specifically, well, how much is this going to cost me since I'm an observation versus an admission? It's never something you're going to be able to calculate. It's never going to be something that anyone in the hospital can calculate, because there's a lot of factors that go into it, because there's for each one, there's deductibles, there's co-insurance, and it resets if you don't use your Part A for a long period of time, and it's a beneficiary period. So there's a lot of calculations go into how much a patient would end up having to pay versus if they're an inpatient. It's not always more. More often than not, it is more an observation, but it's not always more, depending on where they are with their deductibles and such. So don't try to get into the trying to calculate it for the patient. I think the answer to that question was you don't qualify for inpatient admission and you could be charged more is the perfect response. So that's just my 2 cents.
Thank you so much, Matt. Yeah, I mean, what I was discussing was a good chunk of our Medicare patients, and obviously for every insurance, it's different. But the general principle is just to keep that in mind, that it's going to vary for different cases, and you just have to try to work with the system to give the most efficient care to that patient.
Well, I think this was a very good presentation with good examples of what we should be doing on observation. But my only question is, so you mentioned about the recovery audit contractors, but who's there looking out for the patients? Because the main problem, the only problem that I've really seen is patients who we can even have sometimes on a Bumex infusion, or when we have Bumex for 2 or 3 days, and they're clearly inpatient, but they remain on the observation unit. Now, when these patients go 2, 3, or even more days, and we've requested beds 2 or 3 days in a row and they remain there, if we discharge them home, are they going to be billed for observation services rather than inpatient that they were appropriate for?
Very, very good question, Dr. White. So, yes, a lot of our patients, we are the ones who need to bat for our patients. So, a lot of them will have a high intensity of treatment, will have a high severity of illness. It is absolutely critical that we, make sure our documentation reflects that. So, if we just say CHF exacerbation on Bumex for diuresis, that really doesn't fly, and anybody looking at it will not know that this patient had an acute and chronic diastolic or systolic heart failure with an EF of 15%. You have him on Bumex diuresis and he has another 20 pounds of water weight to lose. So that difference in documentation will help you make your case for admission. At Henry Ford, Maine, sometimes, especially when there is a lack of bed, patients end up staying in the observation unit, even though they are fully qualified to be an inpatient. Sometimes they're approved for an inpatient, but they end up staying in the obs unit. Those patients will be converted to an inpatient status, even though they're physically not on the inpatient status while they're in the hospital. A
Oh,
downtown ops unit works in a different way because our ops beds are not approved inpatient beds. So we may not be able to convert them to inpatient right at their same location like we can do in other places. For example, on H5, you can have a patient on OBS and you can put an inpatient order and you can instantly convert it to an inpatient because of the fact that that bed is an approved inpatient bed. Whereas in our CDU, in our observation unit, those are not approved inpatient beds. They are approved for observation status. So we can't flip them to an inpatient status right then and there. We have to wait for an inpatient bed to open up in the rest of the hospital. So sometimes there is a delay. Sometimes, even though they qualify for the inpatient status, they end up remaining in the unit. It doesn't mean that they're going to be carrying the cost of care. That case will be reviewed and converted back to inpatient in the review process.
oh, okay. Okay. That's good to know.
Hey, any other questions? So I think it's almost time. So I just wanted to remind everybody before we go that we have our observation journal club, which will be on Skype. Unfortunately, I couldn't get Zoom in our CFP room, and our guest speaker is more used to using Skype for his presentation. So that will be on the Skype platform. So I know some of you logged into Skype before joining this meeting. I'm sorry for switching between platforms. And our next lecture will be next Wednesday. So we're going to have lectures every Wednesday. It's going to be on chest pain and stress testing. It's going to be a very interesting lecture. Our cardiologist here at Henry Ford, Maine, Dr. McCord, had accepted to come in and be a guest speaker there. So I'm really excited for that lecture, and I'm hoping everybody can join in. Our journal club this Friday is going to be on high sensitivity troponins. We're going to have an expert commentary from another one of our cardiologists, Dr. Hudson, who's going to be joining in. And he's going to talk about our protocol here at Henry Ford, Maine, and which is soon to be rolled out to all of our community hospitals as well on the use of high sensitivity troponins. So I'm hoping you'll be able to join in for our Friday session, which is again at noon, and our every Wednesday session every week. So this is going to be rolling lectures. Those of you who missed it this week will be able to, catch a review of this in the next set of lectures. And we'll also try to make a recording available for those who were not able to join in for the live presentation. All right, if there is nothing else, thank you everybody for joining in. It was a wonderful session having you all. And if there is anything else, just shoot me an email. I think you all have my email now from the invite that I sent you. If you have any questions, concerns about observation unit and operations, I'll be happy to answer. Thank you.
Thank you, Brian.